Hello and welcome to the Egg on Air live session with Enrico Santos. I'm Gia Mirando, Director of Marketing here at Data IQ, and I'm thrilled to introduce Enrico as he discusses natural language processing and the challenges and opportunities to improve the healthcare system. Enrico, thanks for joining us today.
Hi. Thanks for the invitation, and hi everyone.
So before I pass the floor over to Enrico, I wanted to share a bit about his many accomplishments. Enrico Santos is a senior data scientist at Bayer. His academic career includes a postdoc at MIT and numerous years spent between Asian and European universities, working on topics such as NLP in oncology, NLP in cardiology and palliative care, fake news detection, and sentiment analysis. Enrico has published over 100 papers, and several works were featured on mass media. He has been invited to talk at the White House and is the first author of a fact sheet about AI for the American Congress. Enrico has also supported the creation of a mouth-shaped robot that generates original prayers through GPT-2. The artistic experiment, ideated by Diarmuid Streb, was exhibited at the Pompidou Center of Paris. So without further ado, Enrico, I will pass the floor over to you.
Thanks a lot. So let me share my screen. And can you see it? Let me know when you can see it.
We are good to go.
Okay, great. So thanks a lot for the invitation. I really appreciate. Thanks to Egg on Air and all the people that supported me from the logistic and technical perspective in these days. As you can see from the title in the slide, today I want to speak about natural language processing, challenges and opportunities in healthcare. And you know that the recent pandemic has made very clear that our healthcare systems are actually fragile and they need some changes to be more sustainable, and we need to work to make them more efficient and effective. This can only happen if we rely on data-driven approaches, which rationalize the processes and improve and optimize the allocation of resources. And finally, the final goal of this is to move healthcare not anymore in treating, but actually in preventing and in personalizing the treatments. So given this intro, I'd like to start this journey with you. Historically, humans have always looked at correlations between events. This is something that we could have seen already in the ancient Greece. You can see in this slide the Delphi oracle, and on the right you can see the Lotus numbers. Already 4,000 years ago, in the city of Mary in Mesopotamia, there were stories about women that could speak the words of God. Since then, this idea of the oracle passed through the Egyptian to the Greek culture that has utilized it so much that most of its literature relies on oracles, actually. And at the time, oracles were reading the futures through the gut of animals or through the flying of the birds, or they could even listen the words of God in the wind. Today, this may make us laugh a little bit, but make us smile. But actually, the truth is that we still look for correlations, sometimes also in crazy ways. And the Lotto here is just an example. There's people that connect their dreams, relate their dreams to the numbers of Lotto, especially in Italy, where I come from. So this happens because humans need to find correlations to try to find ways to explain the reality. Reality is very complex, and we try somehow to find somewhere to connect the things, and then act accordingly. In the complexity of the reality today, this is even more true. If you think, for example, the stock market, we want to predict the stock market to do the right investments. If you think about healthcare, we want to predict the future diseases so that we can actually prevent them or monitor them and maybe try to treat them very early in the processes. Obviously, today we cannot look anymore at the gut of the animals, but we need instead something that is a little bit more reliable, such as statistical methods, right? Powerful statistical systems that can analyze historical data and, given certain cues, try to extract insights, and from the insights allows us to make predictions about the future outcomes. So this is the world of artificial intelligence in 2 words. Predictions are, of course, highly tied to decisions. Let me explain it better. Whenever we make a decision, what we are doing is simply trying to imagine all the possible outcomes and then act to support the outcome that is most favorable for us. So that's about making decisions. And it is estimated that a human being makes about 1 million decisions per month or more. So, of course, most of these decisions are related to what to eat, where to go, which street to take rather than another, and so on. But still, these are all decisions. As you can imagine, this issue is particularly important for the industry. In the industry, decisions affect the revenue. And in some domains, like the one in healthcare, they affect even human life. We could have seen this in the recent months when the decisions taken for contrasting COVID have actually affected the outcomes pretty much. So the countries that have relied the most on the data have actually optimized the lockdowns without actually destroying the economy and saving life on the other end. The other countries some other countries may have let's say, abused of the lockdowns, and so they have hit the economy brutally. And some others instead have done exactly the opposite. They haven't closed anything, and this has affected the death tolls. So take advantage of this point to thank all the people that are fighting against the virus as frontliners, by the way. Okay, so making the right decisions requires the right information. If you look at this slide, you see basically nothing, because this slide is not very informative. Whenever you want to go from a point A to a point B, so you see in the slide, you see the we are there, and you see the goal. And you can imagine that a company has something like that. It has to go through some steps to reach certain goals, which may be tied to the revenue or may be tied to other business points. But there is a way to reach that. If you have bad information like this map, it's very likely that you will never reach the goals, because you're going to get lost on the way, you waste resources, you waste energy, and so on. So maybe you need a little bit more data, and maybe you can actually find the path to get to the goal. This map that you see in the slide is slightly more detailed, so you can kind of understand what the path may be, but yet you may get lost on the way, and maybe you also waste a lot of energy. But at the end, possibly you're going to reach the goal. And this may be the optimal case, the optimal situation in which you reach the goals without actually wasting time, because you can rely on the historical data, on the experience of others, and actually reach the point that you had decided to go through. So similarly, in artificial intelligence, in data-driven approaches, what you try to do is to exploit previous experience, previous data, and try to learn patterns, trends, and extract insights that can help you to predict the outcomes. And once you predict the outcomes, you can somehow act to favor one outcome rather than another. And this is possible thanks to what is known as big data, right? This name is now pronounced everywhere. All the media are talking about it. And big data are characterized by several V's, and I'm going to describe 2 of them now. One is the velocity. 90% of the data is being created in the last 2 years, with 50 times growth per year between 2010 and 2020. Just to give you some examples, we have generated 2.9 million emails per second. we have generated 20 hours of YouTube videos per minute, and we have generated 50 million tweets per day. Of course, with such velocity, we are also creating a lot of data and storing it and saving it. So we ended up having 44 zettabytes of data in 2020, starting from 4.4 in 2013. You can imagine with such a huge amount of data, you'd need a huge storage rooms, right? If you were to save all this data into tablets, you could have as many tablets as you need to do 6.6 stacks of tablets between the Earth and the Moon. This just to give you an idea of the quantity of data we're talking about. But the question is, how are we actually using all this data? Well, not really. In 2017, McKinsey noticed that 90% of business decisions are still made on the education of the employees, their instinct, and their gut feeling. And similarly, in 2016, PwC noticed that 2/3 of the healthcare decisions are rarely based on data. And the reason is that whenever we look at data, we imagine something like very well organized, like this slide, right? An Excel file with plots, charts, tables, and so on. The reality is that big data looks much more like this. So it's basically impossible to take out insights from data that is not well and properly organized. We have reached the paradox that we are overloaded with data, but yet we are underinformed. And the reason is that on top of these two V's that I described before, velocity and volume, there are other two V's, variety and veracity. So the variety is the fact that data is generally generated by people for people. So social networks, forums, EHRs, text, whatever. Everything is organized in form of text because this is what humans can actually appreciate. Unfortunately, this is not the same for machines. Machines are better with tables and numbers. And on top of this data is not generated in the same format. So you have a lot of formats which are not interoperable. And of course, because they are so many formats, it's impossible to aggregate this information and try to have the broad picture out of all these details that we have generated. And similarly, for what concerns veracity, data contains bias, such as gender bias, race bias, and so on. There are some categories that are overrepresented, some categories that are underrepresented, and so on. But there's also the possibility that data is dirty. There's noise inside it, and so it hides the signals, the important signals. So we have garbage in, garbage out. Other things related to this is the anomalies. So there are some anomalies that can be even malicious. So there may be people generating fake data, such as the fake news, to confuse us and to confuse the systems that rely on data. And so here now we have the real picture of big data. It's not as bright as we look at the very beginning. There are some problems. And according to IBM, these problems amount to, in terms of cost for the United States only, is about $3.1 trillion. Okay, so we are talking about a lot of money. And this is true, especially in the healthcare domain. There is a big effort in the recent years to try to take advantage of data, but the truth is that we are still pretty far. So here you see in this chart on the left, you see the curve of the available data, which is growing in an exponential way. And then you see the straight line of what we are able to do with this data, which grows in a linear way. Of course, in the middle of the two lines, you see a big gap that is likely to grow in the next years, except if we actually work in the right way and we start utilizing the proper algorithms. So focusing on the healthcare domain, until today, 80% of the data is unstructured and untapped after its creation, meaning that doctors spend about 50%. There are several estimates that say that doctors spend about 50% of their time to create and generate EHRs and other kind of medical notes, and then this data is never used. In fact, some other surveys have shown that 65% of the times healthcare providers are unable to view and utilize the patient data before their encounters. So a big effort to create this data, and the impossibility of actually exploiting it. On the patient level, this has, of course, enormous consequences in terms of diagnosis errors, treatment errors, and so on. On the population level, it means that we actually are not understanding the disease that we are looking for, right? Because what you have like very few data points, and you try to somehow understand the complexity of a disease from a few data points that you have. So we have socioeconomic information, patient medical histories, diagnosis, treatments, genetic information, and so on, that are there for the benefit of no one. And that's also the reason for something very sad. Actually, among the 3 top causes of death in the US, the third one is the medical errors. And it counts for about 250,000 deaths per year. It comes just after cancer and cardiovascular diseases. And of course, if we were able actually to exploit all this data that has been generated at very high cost, maybe these errors were not going to be there. And also, if we were able to generate this information in an easier way, doctors could spend more time interacting with their patient, and so actually understand more about their life and their problems. So how does it work when we have these kind of problems? What can we do to somehow contrast them? Well, in order to draw insights from unstructured big data, what we need to do is to turn it into smart data. And this can be done like we have the unstructured data, like in this slide, and then we try to utilize text mining approaches to turn it into something like Excel spreadsheet or databases and so on, something structured that we can relate, we can count, and so on. And once we do that, we can finally extract insights and utilize them for actionable for actions, right? And but how can we do actually these steps? How can we go from the structured data to the structured data? Well, so far the main methodology is an outdated one, which is utilizing humans. Humans need to read sequentially and not in a kind of unsequential way. We know that information is not always organized sequentially, right? You can find it in different parts of the text. And reading sequentially, they can read up to 1,000 words per minute. They must be very good readers to read at that rate. But supposing they are good readers, 1,000 words per minute with 85% of understanding, which actually tell us that if they were going to read the big data, it would have taken them ages, okay, independently of how many people you use for doing this extraction. And that's the reason why, as of today, it was noticed by ASCO Cancer Link Q, most of the clinical decisions are based on the population that participated in clinical trials, 3% of the population. So we are analyzing 3% of the population, we are studying this 3% of the population, and then we generalize the findings on this 3% to the rest of the world. That means that 97% of the population are actually utilizing something that was tested and studied on such a small percentage of people. It's obvious that if we do that, we end up in a situation like this one, where we have to appreciate the Mona Lisa by looking at the picture on the left side, right? And it's basically useless to try to appreciate Mona Lisa on that picture. We would benefit much more if we had the full picture on the right side. So moving from here, we have to think about what would be possible if we were going to exploit this data. And so here we see several clinical applications. If we were really able to look into this data in a smart way, we could support preventive and personalized care. So we could develop algorithm for risk prediction. We could, so that means that if somebody is going to have cancer in 5 years, is likely to have cancer in 5 years, we can monitor and we can detect earlier, right? So we can have early diagnosis. And we know for a matter of fact that if we detect early, we can treat early, and the treatment is more effective on early diagnosis. Also, we can select the patient for the treatment. There are, not all treatments are the same, so we may want to give the best treatment to the patients that will respond to it, right? So patient selection. And also we may learn about their genomics, variances, genetic variances, and so on. And we could develop treatments and discover new drugs that are more effective for those specific patients. So a kind of tailored medicine. And a way to achieve that is to utilize something that you probably have heard about, which is natural language processing. Natural language processing is a branch of artificial intelligence, and it deals with understanding, manipulating, and generating human language. It's a discipline that is recently on all the news with this GPT-3 that creates fake news or generates crazy text and so on. There is a lot of hype, which is somehow good because it brings the technology in the homes also of the people that is not somehow aware of it. But it's bad because it creates false expectations and confusion about the goals of these technologies and what they could have actually been used for. In the last years, I've worked with MIT, Bayer, Microsoft, and other companies in several projects. Like in the last 2 years, mostly 2-3 years, mostly related to the healthcare. In particular, I've tried to turn hard copies documents into digital forms using OCR, like optical character recognition techniques. I have utilized the system to get this digital document and classify them according to some criteria, such that they could be either archived or they could be utilized as a representative of certain characteristic of the patient, for example. I've also utilized these natural language processing techniques to identify relevant information within the documents. So going through the text and finding what is relevant without the need of having a human doing so. And I've also collaborated to projects for retrieving evidence and classify claims on whether they were true or not. This was helpful for fake news detection. And finally, we have worked in several cases to develop algorithms for helping clinical decisions, for example, for risk prediction models or patient selection models. And I am going to showcase one of these later. So let me start with one of the two use cases that I'm going to talk about. The first one is about extracting information from EHRs and structuring it into Excel files, such that doctors can look at the Excel files, make their counts, and understand how certain issues are frequent, how frequent they are, how they correlate one issue with another, and so on. And we try to do this across institutions because, as you probably know, every institution is currently utilizing different formats of data, and generally, like the highly used rule-based approaches are unable to generalize across institutions. So we wanted to test whether neural networks are actually able to do so instead. So the goal of the research was twofold. On the one side, we wanted to substitute the imprecise and very commonly used rule-based approaches. On the other hand, we wanted to verify whether these approaches could generalize across institutions. This project was a collaboration between MIT CSAIL and MGH, the Massachusetts General Hospital. So imagine you have a note like the one that you see there on the left, where there are some important information. In this slide, you see this information in bold characters, but of course, in the real notes, you don't see them in bolded characters. And then you want to extract this information into a table format and say whether something is present, absent, and so on. So given this goal, we collected about 25,000 notes from 7 hospitals, 5 coming from the Boston area, and 2 coming, one from Detroit and one from Pakistan. This was to give to our universe more variability, right? And the population was mostly white. You can see it's about 77% white, even though other races were represented in small parts, like African American 4%, 3.5% of Hispanic, 2% of Asian. And then we had the part of the population that we didn't know what was their race. All our patients had an average age of 56 years old, and they were visited between 1987 and 2017. And of course, the highest majority were female because we focus mostly on breast cancer, as you can notice from the picture above. And here is the system, and I'm going to explain you very shortly how it worked. So given a node, like the one that you see on the top left, this node is transformed into a table, into a matrix of embeddings, where every embedding is somehow representing a word through a vector. And this matrix was passed through a convolutional layer, and then max over time pooling layer. And finally, there was a softmax that decided that established the probability in the classes, in the output classes. The output classes were always two. There was present and absent. Okay, yes or no, however you want to call it. It was a binary classification. And here are the results. You can see that we have three settings. One is the single institution, one is the two institutions, and one is the four institutions. So what does it mean? It means that the system was trained only on one institution, or two, or four, okay? So what we are trying to test is whether the system, how the system performs in the institution that was known during training, but also how the system performed in the institutions that were unknown during training. And if you look at this chart in the x-axis, you see that there are the samples. So you see that as the samples grow, also the accuracy of the system grow. Another thing that you may notice is that all the systems perform above 90%, actually above 91%, I believe, all of them, when they have at least 1,500 samples in training, which is great. So, and if we look carefully, we can notice also other few things. The single institution system performs pretty well in the known during training institutions, so the chart on the left in this case, but it performs very poorly in the chart on the right. I mean, poorly is the wrong adjective because it's still above 91%, but it's performing worse than the other two settings. Why? Because the other two settings were trained on multiple institutions, one case 2 and one case 4, and in that case, the system had to learn how to generalize to new institutions. What you see is also that there's not a large difference between the two institution one and the four institution one. Even though the four institution, if the four institution has more data, then it starts around 2,500 data points. It starts getting better than the two institutions. Thanks to this system, what happened is that researchers at the hospital were able to look into data in a massive way and aggregate way. So the studies that they produced were not anymore based on 300 or 600 cases, but finally they were based on 6,000 cases. Of course, again, if you remember the Mona Lisa, and the previous studies were looking at a very low resolution picture. The new studies are looking at a very high resolution picture. So more understanding of the problems, and also more understanding of the clinical cases that they have to deal with. When you are comparing one case that comes to the hospital, you don't need to compare it anymore to like a couple of cases that you have visited in your personal history, maybe last week, but you can compare it to really a large amount of cases, and so make better clinical decisions. This system was also expanded to cover other organs like brain, lung, pancreas, prostate, and so on. And finally, I go through the second case study that may be helpful for the discussion of today, and then I'm really open to discuss with you. This case study is about has a different goal. It's not about extracting information for retrospective studies or similarity, but it is exactly for a clinical decision. And the clinical decision in this case is patient selection. So we have a therapy which is called cardiac resynchronization therapy, and we know that this therapy is positive in many cases, but not always. And we want to identify which patient will benefit out of it and which patients won't benefit out of it. This was a collaboration with between MIT and Dana-Farber, and we work on this with the group of Charlotte Lindvall. So the CRT is a well-known procedure to reduce heart failure hospitalization and improves survival, but it's also a risky and expensive procedure. What we know so far is that about 1/3 of the patients do not benefit out of it, do not get any benefit within the 18 months from the procedure, which are the 18 months that are used for the assessment. A subgroup of these 1/3 even die for complications or comorbidities. So you can imagine that trying to identify this subgroup would actually help to improve the life of these patients that are undergoing a procedure that is not helping them, is costing them a lot in all terms. To achieve our goals, we collected 990 CRT patients, again from Boston hospitals, that were visited and undergone procedure between 2004 and 2015. The mean left ventricular ejection fraction for these patients was 24.8%, and we measured the benefit as improvement in the left ventricular ejection fraction. So if there was no benefit, not improvements in this parameter, we consider like the procedure was not beneficial. Another way to consider the procedure not beneficial was death within 18 months from the procedure. We identified the 403 patients, which are basically the 40% of them, which had reduced benefits. 25% of them had basically not improvement, while 15% of them actually, unfortunately, die within the 18 months. The patients were on average 71 years old, 78% of them were males, and 87% of them were white. And each of them had an average of 75 clinical notes, meaning that they were having a lot of visits with the hospitals. What we tried to do was to leverage a lot of unstructured and structured data, including demographics such as gender, age, or past health services utilization, bill codes, encounter information, for example, how long it was and what type of encounter was that, laboratory values, medication, clinical information, EHR narrative, and so on. So getting all this information, we tried to structure it into vectors and then passing these vectors to a machine learning method that could give us some predictions. The patient sample was divided in 80% for training and 20% for testing. This is a typical approach. We trained 4 classifiers, logistic regression, subtle vector machine, and random forest and extreme gradient boosting, where the last one was the the one that performed the best. And you see here on the chart on the right how we combine basically the structure and unstructured information to create the features and so on. This is a representation of what we have done. And we did a 3 cross validation in order to identify the best parameters. We optimize F-beta score. And finally, once we had identified the parameters, we tested the system on the 20% of the test. The results are interesting. You can see them both in the numbers that I'm going to say and also in the figure that you see there on the right. So given 100 patients, we were able to identify 26 people, so 26% of the people that were not going to benefit out of the procedure. and we identified them with a 79% precision, which is actually very interesting as an initial study. So here we go towards the conclusion, and no, there are no big conclusions in this presentation, because we have just started. NLP is being applied just now. What is important to say, just to give a little bit of context, is that the United States spend about 70% of its GDP on healthcare, and if you compare it to other countries in the Western world, you see that 12%, about 12% of it is public, and the remaining is private spending. So we're talking about a big cost that is getting on the population. Also, what is interesting is that if you calculate this 70% is about $3.7 trillion, and they are about $10,000 per capita. Okay, so that gives you a sense about how much they are spending in the US. So definitely there is the need for optimization and making this system more sustainable, and possibly also more open to everyone. NLP can definitely help this effort. It can help, for example, to manage to the growing clinical data. It can help to structuring and completing the EHR, such that the doctors may spend more time with the patients rather than spending the 50% of time I mentioned before with writing notes. It may help to improve the retrospective studies, so giving us a better understanding of what's going on with certain disease. It can help to support the value-based care that is meant to improve prevention, early diagnosis, and so on. It can help the drug discovery. One thing that I haven't said so far is that drug discovery is a process that is very expensive. It cost about $2 billion in 8 years to develop a drug, and I mean we are talking about costs that can be cut by a big percentage if machine learning, natural language processing are used. Also, what else it can help is the individualized care. So precision medicine and personalized care, thanks to the utilization of information on big data and genomics, and can improve also the quality of the interaction between the doctors and the patients. And because of all these reasons, it shouldn't surprise us that NLP in healthcare in the next years will have a compound annual growth of about 20% per year, passing from 1.5 billion of US dollars to 3.7 in 2025. And the only conclusion that I can say out of it is that if we were starting to use NLP before, probably this 2020 would have been a different year. Thank you.
Thank you so much, Enrico, for sharing your expertise in what is clearly a very important and timely topic. So we have a lot of great questions that have come in so far, and I want to get to as many as we can, but also encourage the audience to please continue asking questions in the chat, and we will share them with the audience. So let's dive right in here. Katie asked a question. What do you think is the #1 benefit for data and analytics in the healthcare space that has resulted from the global health crisis?
The best benefit for data, and I'd say that is only making us aware of the importance. I remember when this crisis started in January, I was in Hong Kong, and in Hong Kong, everybody was using the mask, and me as a Westerner, I was not using the mask, and I was not using it because I was not aware about how serious this thing could have been. Because I didn't have historical data, right? Instead, in Hong Kong, they had experienced it before, and they knew how risky it was. So that was my personal behavior. But then when I went to the US, in the US, everybody was very much convinced that the virus was only in Italy, because in Italy, people hug each other. And I was like, okay. And then I realized, like, wow, our perception is so based on data and the preconception, and if your data is wrong, you're totally wrong, right, in your conclusions. And as the epidemic and the pandemic went on and on and on, we realized how important were to make all the counts and try to understand better. And this has helped us so far.
Mm-hmm. Absolutely. Let's see. Next question from Myra. Is one of the NLP applications in healthcare more pressing than the others? So example, medical records, academic literature, journals, social media, etc.
Can you tell me the first part of the question?
Yes. Is one of the NLP applications in healthcare more pressing than the others?
Yes. I believe, honestly, that dealing with EHRs is very pressing because, as I said, like doctors spend a lot of time to create EHRs, and we may simplify this process of EHRs creation, but we may also simplify the process of EHR understanding. So extracting information from this EHR. I believe that's crucial because then after that you can really do a lot of analytics and understand quite a lot about the phenomena.
Here. Next question is, in your opinion, what are the most critical steps healthcare systems need to take in order to take better advantage of AI and be prepared for future crises?
Yeah, I mean, more than what the clinical part needs to do to get prepared is probably education. Okay, from that side, I think education. So there is a lot of resistance in utilizing these methods, fear, and people are not well educated about the potentialities that these methods have. But I have to say there are also real technical problems. For example, the interpretability of the system. So it's not all to blame on the clinical side. There is still a lot that needs to be done on the engineering side. But I believe that we should start finding some use cases where, for example, interpretability is not crucial, is not that crucial anymore, and maybe utilizing. I come from the pharma domain, and in pharma, there are some regulations that say that if a pharma company is aware of an adverse event, they need to report within 24 hours, and there is a lot of burden because you risk a lot of troubles coming out from reporting that, especially if the adverse event is in social media. So what pharma generally do is they don't monitor social media, because monitoring social media means a lot of burden to be added to their pipeline. And this is a problem in the regulation. I mean, why don't you allow to use some automatic methods that may not be perfect? They may make mistake, but still they are monitoring a new source of information that is currently not monitored. So that's where we have to start working.
Okay, great. Let's see. As we wait to see if there are any, we got one more question. So let's see. If there are different kinds of input data, such as in the form of text, numerical, then how do you go about producing embedding vectors? See if I understand that in the way they intend.
There are different kind of input data, such as in form of text, numerical. Then, so in form of text, so I think she has some understanding of what we are talking about. So in form of text, you can utilize existing methods like word to vector, or you can utilize the embeddings, contextualized embeddings such as BERT, GPT, the various versions, and so on, for the contextualized ones. For numerical, it's a complex issue. They also actually, especially the contextualized embeddings, generally can give you some embeddings too. The problem is that they are not perfect. We are still very bad with numerical embeddings.
Right. I think we have time for one more question. How should we address NLP's need for sample EHR, EMR training data while staying within guidelines for personal privacy and corporate desire for proprietary solutions?
Well, that's the toughest question. I have to say. Here, there is it's a very delicate topic that where I'm not an expert and I don't want to expose myself very much. But I think at a certain point we have to think about the benefits and the drawbacks of anything. If our data is utilized by the insurance company to take advantage of us, such that they know something and they don't pay our visits and so on because they know something, then it's a big problem. And I totally agree with a high privacy standard. But if it's utilized for good, for understanding more one specific type of cancer and so on, then maybe we can renounce to our privacy for the good of everyone.
Mm-hmm. See, get to one more. How about the reproducibility of the results obtained by NLP? How confident are you in their accuracy? Do you think that if we use the same method, we can get the same results and then the same results in another database? Understand the end of that?
Yes, that's a very good question, actually. Reproducibility is a major concern, actually, especially in the healthcare domain, where people do experiments on hospitals that don't release the data set. So what you have is that nobody can actually verify whether these results are actually true unless this is used in production. And this was the case for us. It was used in production, but that's a big issue. Also, for what concerns the generalization to new data set and new databases, it's complicated. It's very much complicated. This is one of the reasons why probably NLP is still not well spread around. We know that it works very well on synthetic data sets, so data sets that are very well curated and so on. But then when you put NLP on the real world, sometimes it doesn't perform as good. And yeah, definitely this is the major issue, and there's something that we need to work on. The experiment that I showed before, where we trained on multiple institutions and tried on the new institution, was exactly meant to test this thing. We were trying to see whether it was going to work on a Pakistani institution that nobody has trained on. Yeah.
So unfortunately, we are reaching the end of our time. Enrico, I want to thank you once again for your incredibly insightful talk today. And thanks to everyone out there who joined us live. I want to share a little bit about our next 8 on-air live streams that are coming up. So on December 3rd, Arnold Luang will discuss supply chain distribution. We have Nicole Alexander on December 10th talking about explainable AI. And on December 17th, Anthony Angone will take on fraud detection and authentication. So until then, we will see you all on air soon.
Thank you very much. Thanks.